Okay, I think I'm up next. I hope everybody can hear me. Great, thanks. Yeah, so this question I found very challenging, and it's a very complex one. It's actually three questions, as you can see. So, but I'm going to sort of just say a little bit about them in total and try to cover it. I thought one way one could maybe synthesize and look at understanding the key themes and issues in the question would relate to data work, AI, and expertise. We're thinking about concepts and ideas. Some of the questions that you might have, how is data work, first of all, changing in the era of data-intensive computational tools? What's actually happening? If we think about it, we're seeing, for example, the data production. Who's doing what now differently? And what we do see is very much the technology, the remote technologies with the patients offering up and producing a lot of the data that wasn't there before, which is different from, for example, within a hospital where it would be all bound by doctors with the patient. So that leads you to thinking about where and how, what's happening here in the data travel and the extent to which and how this generation of personalized data is now being directed and used in different spaces, whether it's the home or other communities, let's say community healthcare. And indeed, as was mentioned earlier, Batya, the new roles that come up with that, the data curators and the stewards, these are very important to understand what's at work here, how are things really changing, if you like, alongside traditional data work, which is happening for patient monitoring. And I had a very good, interesting discussion over breakfast with Leo, I think is here at the back, and Eivor. And, the whole idea of the role of AI and algorithms in analyzing data. And he was referring to, of course, the robustness of the algorithm. And Stella and others have mentioned that just now in the sense of, the extent to which and how doctors are having the opportunity to update algorithms, especially, and it's certainly in Natalia's and other papers, where that human in the loop is really important in how you connect clinical and research algorithmic data together in sort of more real time. If that's possible, both regulation at the hospital level as well as wider regulation. So it raises a lot of very interesting promise and challenge issues that we see around data work and how that's changing with AI. Second part, I'll lump the two together in the interest of time. But the idea of the notion of, well, I have to read it very quickly. I was struck by it. Patients now consume the doctor's professional expertise and the wealth of AI-generated predictions to inform their predictions. And I thought, oh my goodness, consume is a very strong word. And that got me to think about how are we understanding expertise? How are we thinking about ways of knowledge and tacit knowledge, knowing, and what are the possibilities as well as the limits for patients in being able to consume AI-generated predictions. And so there's lots that could be said conceptually. I've always found interesting Collins and Evans's work on redefining expertise and trying to unpack and understand how we look at this issue. Indeed, one of the things I'll just say briefly, so as to not seem like, sorry, Samar, you've got me rolling, the dinosaur, which doesn't see any possibilities for the patient. As indeed, of course, the patient can develop this sort of popular understanding of healthcare, but we'll never get to that primary source knowledge level as Collins and Evans would refer to. Indeed, if you think about it, even doctors, many doctors who don't have the time, who are not involved with the actual evidence-based development of data, are limited in how much they can even make sense of that evidence-based knowledge. So I think we have to be very careful about the limits, but also see that there are, indeed, there's more information, there's possibilities. And as the question goes on to suggest, that has implications for the relationship between the patient and the doctor. But in terms of the credibility, I would just say, well, there's the interactions. What we're seeing, as I mentioned at the very beginning, is the way in which the access and the monitoring of data of the patient, remote monitoring, does allow for a better picture of patient's health beyond the snapshot often seen in a single appointment or an episode. For inpatient care, it's interesting because some of the recovery now of patients can be moved into the community and the patient's home, therefore reducing length of stay and therefore costs. And indeed, technology can be used to try to ensure that one does do no harm to the patient by the monitoring, knowing when they might be becoming unstable to bring them back in to the hospital for readmission if and when that becomes the case. So we're seeing a much more complex set of hybrid models of care, which have implications for that relationship and many more possibilities that are generated as a result of that. Just lastly, I'll talk to you about the eye hospital that we were doing some work in. The idea of how AI, for example, in personalized medicine, can be used to predict disease is really, truly fascinating. Again, the promise, I'll end on a positive promise note. But the sense of being able to, predict disease is phenomenal from patients and scary at the same time, from routinely collected eye photos. That's where things are going. And of course, you can see why the scary bit comes in, because those images, which will be on the net and everywhere, insurance companies or whoever may be using, just as we see with interviewing or recruitment, different sets of data over time, if we're not properly regulated or aware of it, in how care is offered and at what price to patients. So prediction has amazing possibilities and also potential consequences. Thank you.